My name is Dr. Colleen Wood, and I'm a pediatric endocrinologist in Billings, Montana. And I am extremely pleased to be here with my co-chair, Dr. Amanda Brennan, for our topic, Emerging Topics in Endocrinology. We are joined by 5 fabulous speakers today with really 5 fabulous topics. We're going to start off with an introduction from my co-chair, Dr. Amanda Brennan, and then move into his talk about pancreatic and islet vasculature by Dr. Josh Castillo. Moving on, we'll have Dr. Soon presenting about SGLT1 and 2 inhibitors and how they affect the pancreatic endoplasmic reticulum. Then we'll have Dr. Gregory Ratai talking about the development of metabolic syndrome after the start of elexacaftor, tezacaftor, and ivacaftor. Next, we'll have Dr. Lee talking about pregnancy and outcomes in the era of Cftr modulators and the COVID-19 pandemic. And we'll end on Dr. Puri talking about testosterone deficiency in men with cystic fibrosis. And with that, we'll lead into our first introduction by Dr. Amanda Brennan. Thank you.
Good morning. Dr. Colleen Wood and I would like to welcome you to the workshop on emerging topics of endocrinology. I'm Amanda Brennan, and I'm an adult pulmonologist in the UK. During my training, my PhD focused on cystic fibrosis-related diabetes, and I now lead the diabetes service in Manchester. Colleen is a paediatric endocrinologist working in clinical medicine. She was a recipient of the Cystic Fibrosis Foundation Envision 2 grant, which was designed to enhance training and research opportunities for endocrinologists involved in the care of patients with cystic fibrosis. Colleen and I have no relationships to disclose related to this presentation. Advances in treatment options for people with cystic fibrosis have led to an exponential increase in survival since cystic fibrosis was first described over 80 years ago. The median age of survival for a child born today with cystic fibrosis in the USA is 48 years. There are now more adults than children with cystic fibrosis, and this is due to low mortality in children and increasing longevity in adults. It is predicted that Cftr modulator drugs will alter the natural history of cystic fibrosis as we know it, and it will increase the life expectancy further. Many believe that the endocrine complications of cystic fibrosis will become more important in an aging population. It is encouraging that Cftr modulator treatment started at an early age could improve some of the endocrine complications. However, most people commencing modulator therapies today will already have established disease. CF management must therefore evolve to recognize and enhance the treatment of the endocrine complications such as cystic fibrosis-related diabetes, osteoporosis, and reproductive health. Many of these emerging comorbidities will have important implications on health, burden of treatment, and quality of life, particularly as the impact of pulmonary disease reduces. The research being presented at this conference will be key to understanding, recognizing, and treating emerging comorbidities. This will improve the quality of life for people living with cystic fibrosis and reduce the risk of developing complications later in life. The workshop today will equip medical teams to offer greater guidance and treatment options to their patients. The first objective focuses on cystic fibrosis-related diabetes, which is a well-recognized complication of cystic fibrosis, affecting up to 50% of adults by the age of 40. However, the etiology is complex and not completely understood. The first 2 presentations will increase our understanding of islet cell architecture and how this could help us identify new treatment options, in particular, the role of medications already approved for treating type 2 diabetes. We will also explore how improved health and longevity will require medical teams to screen for new complications such as metabolic syndromes and testosterone deficiency. Over the last decade, there's been an increase in the number of people with cystic fibrosis who are overweight or obese. Cftr modulation may have been a contributing factor over the last few years. The increase in obesity may have concerning consequences such as hypertension and hypercholesterolemia. CF teams may need to start regular screening and counselling for these complications. The fourth talk will focus on reproductive health. People with cystic fibrosis are living longer and healthier lives and are increasingly interested in having families of their own. The talk will explore the impact of triple therapy on fertility in women and how this may impact fertility counselling and maternity care. We will now hear the 5 presentations which will explore these endocrine complications further and the implications they'll have for care in the future.
Hello, my name is Josh Castillo. I'm a postdoctoral researcher from the University of Washington and the VA Puget Sound Healthcare System in Seattle, Washington. Today I'll be speaking about how pancreatic and islet vasculature are significantly diminished in CF donors, a potential contributor to insulin deficiency in CF. There are no relationships to disclose related to this presentation. We'll start by focusing on cystic fibrosis-related diabetes, or CFRD, which is a common diagnosis among CF patients, affecting nearly half of adults. CFRD is diagnosed when a patient exhibits a blood glucose level of 200 milligrams per deciliter at the 120-minute time point in an oral glucose tolerance test. The primary defect resulting in glucose intolerance is deficiency in insulin secretion from the pancreas. As patients age, the prevalence of diabetes increases, as can be seen here. What is the cause of insulin deficiency in CF? Due to decreased functional Cftr in the epithelial cells that line the ducts of the pancreas, the ducts become plugged, which leads to acinar destruction, fatty replacement, and fibrosis, as well as inflammation. This can be seen in CF and in CFRD patients. This concept is shown in the scheme on this slide. We hypothesize that this ductal pathology in turn leads to alteration of paracrine factors, which are secretions that affect neighboring cells. Ultimately, this results in islet dysfunction, remodeling, and inflammation. However, the underlying mechanisms remain unknown. Our research is focused on islet vasculature. The islet has an extensive capillary network, shown here in green, which is important for supplying nutrients to islet cells and delivery of islet hormones. For example, insulin shown here in red and glucagon in blue to the circulation. However, the islet vasculature, mainly composed of microvascular endothelial cells, also provide key signals that support islet function and viability. The beta cells rely on paracrine factors and a basement membrane produced by endothelial cells to proliferate, survive, and function. If these elements are disturbed, it can have impacts on the beta cell's ability to detect blood glucose changes and secrete insulin accordingly. What we know from type 1 and type 2 diabetes is that the islet capillary density is altered. In these diseases, you can see that the density of the capillaries, that is, the number of capillaries divided by the area of the islets, is increased. We believe this altered phenotype plays a role in islet dysfunction in those diseases. So we wondered if CFRD shared those characteristics. In order to study the vascularity of the islets in CF, we undertook a retrospective study of pancreas samples from CF and CFRD autopsy cases compiled from Seattle Children's Hospital, the University of Washington Medical Center, or the Network for Pancreatic Organ Donors with Diabetes, or NPOD. We analyzed a total of 10 control and 8 CF or CFRD donors. Given the age difference between CF and CFRD subjects, we identified 2 control groups, a young and an older cohort, in order to ensure that our samples were age matched. We also ensured a balanced representation of sexes in all groups. Here we can see example tissue sections from our donors. We stained the pancreas sections for CD31, which is a marker of endothelial cells, showing here in brown. When CF and CFRD donors are compared to control, the amount of CD31 positive stain is qualitatively much less. To measure the amount of area that is CD31 positive and compare the samples, we used Nikon's image analysis software. First, we took the area of the islets that is positive for CD31, which indicates capillaries, and divided that area by the total area of the islet. The islet area was not statistically significantly different between groups. This shows what fraction of the islet area is capillary area. On the left, we first looked at the different age control groups and CF and CFRD groups separately and found no statistical difference. However, when we combined the groups and therefore increased the sample size, we found that the fraction of the islet area that contains capillaries was significantly smaller in CF donors. Next, we calculated the number of capillaries divided by the area of the islet, which is known as capillary density, a widely reported measure of islet vascularity. Here we see a significant decrease in our CF and CFRD donors compared to controls, which is present whether the groups are compared individually on the left or combined on the right. Finally, in a subset of cases, we determined the fraction of exocrine pancreas area occupied by CD31 positive vasculature. Similar to our findings in islets, we observed a highly significant reduction in CF donors compared to control. This indicates that loss of capillaries is not restricted to islets, but affects the whole pancreas in CF. Based on these new data, together with our other ongoing studies in the lab and data from other groups, we believe that abnormal vasculature contributes to insulin deficiency in CF by a number of mechanisms. Loss of CFTR from pancreatic ductal epithelial cells leads to acinar destruction and fibrosis. This, in turn, results in capillary loss, as well as an increase in inflammatory cytokines, and also a decrease in beneficial paracrine factors. All of these act to decrease insulin secretion and may also impair beta cell survival. If we can find a way to safely improve vascular health in the pancreas, we may be able to reverse some of the insulin deficiency observed in cystic fibrosis. I'd like to acknowledge the help and contributions of my mentor, Rebecca Hull, and my current and former colleagues in her lab, as well as other labs that worked closely with us. Also, this study would not have been possible without the patients and their families' contributions. And I'd like to thank the Cystic Fibrosis Foundation for the Fellowship Award and Pilot Award that are currently funding our ongoing research and for putting on this gathering. Thank you for listening.
Thank you, Dr. Castillo, for that wonderful talk. I am a pediatric endocrinologist, so I found your talk particularly interesting. I think that in the era of Trikafta, we have all been very hopeful that triple therapy would really help diabetic patients. The jury is pretty out on whether or not it's going to help them, and I think that really roots in what the underlying pathophysiology behind CF-related diabetes really is. Can you elaborate a little bit about your thoughts about what you think the underlying cause of CF-related diabetes is, and maybe also the timing of appropriate intervention according to your research?
Yeah, that's a great question. Like I showed in the talk, you do see a good amount of insulin staining in the pancreas, indicating that there are still beta cells. They're not sort of completely destroyed, like in for example, in type 1 diabetes, where you see that. We believe that well, it's known that beta cell defects are potential contributor to insufficient insulin secretion, but we think the vascularity of the islets and how significantly it's diminished is a really striking feature, and we think that definitely needs to be part of any sort of treatment with regard to improving beta cell and islet function in the future.
And do you think that you'd have better success intervening early before there were problems, or do you think that there's a good chance that even in older age, this is reversible?
Well, I think intervening as early as possible would be obviously the best, probably the best chance for improved vascularity and avoiding sort of the more severe phenotype. But I think that there are other models of fibrosis where there's been success in improving vascularity, sort of promoting angiogenesis. And so I think there are potential avenues for treatment that we definitely need to study in animal models first and make sure we can, safely sort of harness some of these pathways that have been used in other models. But I think there are sort of avenues of treatment that may be available if we can properly research.
Excellent. And now from our audience, was there a difference in vasculature dependent on the age of the donor?
Yeah, I think like I showed in the data, I think really that we didn't see much difference between the CF and CFRD cohorts, and since those were different in age, I don't think there's a difference in that, at least in the samples that we studied, a difference in vascularity. I think among both groups we saw diminished vascularity. So yeah.
And another question, who is actually from my mentor, Dr. Odie, she's wondering, there was no difference between cystic fibrosis with no diabetes and CFRD. Do you think you will find a difference in islet cell vascularity with greater numbers?
Yeah, that's an interesting thought, because yeah, initially we were definitely hoping to see some sort of clue as to why some patients don't have CFRD, why some patients do. With this particular investigation, we weren't able to see any difference between the CFRD and CF patients, but maybe there are some underlying differences, perhaps genetic, or with regard to different secreted products, or things of that nature that we are so far unaware of, that may be underlying the differences between the two outcomes.
And Dr. Brennan, are you having any other questions come through? Oh, you're on mute.
Not at the moment, no.
We do have about a 30-second lag from our viewership and what we have actually discussed here. So I'm going to ask one last question to give our viewers a few more minutes to chime in with a question. And then if not, then we'll go ahead and move on to our next talk. But primarily, I'm wondering what the next steps are in your research and where you're going with this research in terms of the future of treatment.
Yeah, that's a great question. We definitely want to increase our sample size and ensure that there's no other sort of features that we're unaware of with regard to the overall vascularity. As well, we're interested in the inflammatory state of the pancreas, the fact that there are CD3 positive T cells that have been detected in some patients. We think that's a pretty fascinating characteristic, and so we think there's more to that story, and sort of we think that the vascularity plays a role in the fact that those T cells are able to come into the pancreas. I think that the vascularity may, the fact that it be inflamed will promote the sort of inflammatory response. So we'd like to investigate more into what the role of the impaired vascularity is, and as well look into pathways that we can, like I mentioned before, like that we can take advantage of and potentially promote angiogenesis and try to recover some of that lost vascularity. So these are things that we're currently interested in.
Well, I think this is super exciting. I think anything to do with diabetes is super exciting, but I'm sort of biased. So thank you for your hard work.
Thank you.
Now we'd like to move on to our next talk in line. Also equally very excited about this one. This talk is by Dr. Soon, and they'll be talking about SGLT1 and 2 inhibitor sitagliflozin as it attenuates pancreatic endoplasmic reticulum stress through IRE1 alpha. Now, unfortunately, Dr. Soon has been having a little bit of difficulty with their audio and visual for this talk. So we'll see how well we do with the question and answer section. And if there's some difficulties, we'll see if there's some way to direct your questions to them at a later time. So with that, we'll lead right into that talk.
Good morning, everyone. Welcome to my presentation. My name is Sun. I am an exchange PhD student from University of Michigan. Today, I will introduce my recent work. SGLT1/2 inhibitor sitagliflozin attenuates pancreatic endoplasmic reticulum stress through a alpha XBP1 pathway in cystic fibrosis rabbits. As we all know, CF is a systemic illness with manifestations from multiple organs, including pancreas. Our group cooperated with UNC and Wayne State University, produced CF rabbits by CRISPR-Cas9 technology. Our CF rabbits produce many human-like phenotypes, including pathological features of pancreas. Histological evaluation of pancreas collected from CF rabbits revealed lesions of exocrine gland distension, fibrosis, and inflammatory cell infiltration. Therefore, our CF rabbit is a good model for studying the mechanism of CF pancreatic pathophysiology. In our paper, using chamber of freshly excised jejunal from CF rabbit showed increased short circuit current after glucose addition and decreased short circuit current after fluorescein inhibition compared to that of wild-type rabbits. Fluorescein is a dual inhibitor of sodium glucose cotransporters 1 and 2. It means an increase of sodium-dependent glucose transport in CF rabbits. Therefore, we speculate SGLT may be a target for CF disease. SGLT is a family of sodium-dependent glucose cotransporters, including SGLT1 and SGLT2. SGLT2 is the most exclusively expressed in kidney, an organ that is minimally affected in CF. But SGLT1 is expressed universally, including many CF-affected organs, such as SGLT1 mediates almost all glucose uptake in the intestine. And therefore, we speculate SGLT1 may be a target for CF disease. To confirm our conjecture, we used the Western blot and immunohistochemical staining to detect the expression of SGLT1 in the lung, pancreas, and the intestines of CF rabbits. We observed the expression of SGLT1 is upregulated in these CF-relevant tissues compared to that of wild-type rabbits. These results prove our conjecture SGLT1 is a target for CF disease. Then we want to know about the SGLT inhibitors on the market currently. SGLT inhibitor drug, especially SGLT2 inhibitors, has been approved for treating type 2 diabetes, but there is no effective SGLT1 inhibitors on the market. In recent years, sotagliflozin, a small orally available molecular drug inhibiting both SGLT1 and SGLT2, has gained European Medicine Agency's approval for treating type 1 diabetes. Although SOTA has 20-fold higher affinity to SGLT2 over that of SGLT1, its inhibitory effect on SGLT1 is the strongest among all SGLT inhibitors. As a result, SOTA is the most potent SGLT1 inhibitor on the market currently. We hypothesize the SGLT1 inhibition provides benefits to CF individuals. So we established the SOTA-treated CF rabbits to detect the SOTA's effect on CF disease. About 60 days, CF rabbits were treated with SOTA, 15 milligram per kilogram day by daily gavage. And the intravenous glucose tolerant tests were performed before SOTA treatment and after SOTA treatment. The daily food intake, body condition, and the weight of SOTA-treated CF rabbits were measured. Their samples were collected after euthanasia. The SOTA-treated CF rabbits' body weight gain were measured at 2nd, 4th, and 6th weeks after fed with SOTA. We observed SOTA treatment greatly improved the body weight gain of CF rabbits compared to the body weight of CF rabbits without SOTA treatment. And SOTA also rescued the declined survival curve of CF rabbits older than 60 days. As a result, SOTA promotes weight gain of CF rabbits and elongates CF rabbits' lifespan. The IVGTT data show the CF rabbits after SOTA treatment have higher blood glucose elimination capacities rather than that of CF rabbits before SOTA treatment. The percentage of area under IVGTT curve in CF rabbits after SOTA treatment is lower than that of CF rabbits before SOTA treatment. Therefore, SOTA improves glucose metabolism of CF rabbits. Based on these previous results, we speculate SOTA provides systematic benefits on CF disease, and then we study the mechanism of SOTA's effect on CF disease. The previous study have indicated that the inflammatory response in CF depend on the alpha XBP1 pathway activation of the unfolded protein response, which responds to ER stress, and the splicing of XBP1 is functionally relevant to CF disease. Therefore, we speculate targeting alpha XBP1 pathway may be a therapeutic strategy for CF disease. Then we studied whether the activated alpha XBP1 pathway occurs in CF-rabbit pancreas and whether the activated alpha XBP1 pathway is relevant to the SOTA's effect on CF disease. We performed Western blot to detect the protein expression of SGLT1 and ER stress markers in the pancreatic tissues of CF rabbits. We observed the protein expression of SGLT1, BIP, phosphorulated alpha, total alpha, and XBP1s are increased in CF rabbit pancreas compared to that of wild-type rabbits, and SOTA lead to reduce the protein expressions of SGLT1 and ER stress markers in CF rabbit pancreas. Consistently, the MI levels of SGLT1 and ER stress markers measured by qPCR analysis are upregulated compared to that of wild-type rabbits. And SOTA reduced their MI levels. The HE staining images show there are extensive inflammatory cell infiltration in the pancreatic tissues of CF rabbits, and SOTA alleviates the inflammatory response in CF rabbit pancreas. And the immunohistochemical staining images show the positive staining of SGLT1, alpha, and XBP1S are increased in pancreatic tissues of CF rabbit compared to that of wild-type rabbits, and SOTA decreased their positive staining in the pancreas of CF rabbits. In summary, SGLT1 is upregulated in CF rabbit pancreas and other CF-affected organs. SOTA renders protective effects on CF rabbits by attenuating ER stress through regulating the alpha XBP1 pathway in the pancreatic tissues of CF rabbits. Great thanks to our participators from University of Michigan and Wayne State University. Dr. Xu and Dr. Liang supervised and helped me perform our experiments. Thanks to their support, help, and encouragement. Thanks for your time. I appreciate this opportunity to talk with you. If you have any question, welcome to discuss with me. That's all. Thank you.
So much for that talk. Again, because of my background as a pediatric endocrinologist, I'm super excited about anything that examines other medications besides insulin when we're talking about cystic fibrosis-related diabetes. And so this initial research, I think, is really important when we're looking at our patients with cystic fibrosis. We have had a couple of questions come in while you're talking, and I know that there are some technical difficulties, so I want to roll right into those in case we're able to address those online. Otherwise, I'll read out the answers that you've been able to write. So the first question again was from Dr. Larsenodi, and she asks, do the rabbits have full pancreatic fibrosis before week 8 when they're started on sitagliflozin?
No, our rabbits before week 8 don't have pancreatic fibrosis. They only have inflammation.
And then our next question is, can you explain what the cystic fibrosis rabbits not receiving soda die from during the study so that we can understand what soda is impacting in addition to the glucose control?
I think the major reason of the rabbit dies without the soda treatment is caused by GI problems. I think the soda presents the beneficial effects on CF rabbits is not only for the pancreas, the issue, but also for the systematic things such as the liver and liver problems, and as well as the lung problems. So based on our data, we show the if we didn't show the whole biochemistry data, you can see the almost all of the functions can be attenuated by the soda treatment. It's not only for the pancreatic diabetes and something like that. So for the histology change, it's not because of our rabbits probably is young. So we saw the soda gave some beneficial effects on the glucose tolerance and the glucose metabolism change. So as the data we show here, such as the OGTT, and we didn't show the insulin change. We saw the insulin decreased in CF rabbits, but the soda attenuated the insulin's level back to the normal, I think the normal range.
Thank you for that. And the next question is, are you planning to assess SGLT1 upregulation in the human CF pancreas?
And we have some sample from the CF patients, and it's the LV like the cell line we got from the CF patients, and we did test the SGLT1 expression, and very exciting, we saw the CF patients samples. The SGLT1 expression is upregulated. It's consistent with our the CF rabbits data.
I think that's super exciting. And then the last question that I have here is a two-parter. First, it says, nice presentation. The first question is, do you have an idea of the mechanism underlying the body weight effect on your soda-treated rabbits? And secondly, do you know what cell types in the pancreas are expressing the SGLT1 and ER stress markers?
And for the first question, I think the whole thing's change. The mechanism probably, here we test the ER stress and the inflammation. We think the soda change the whole systematic, decrease the inflammation and give some beneficial effects on the appetite change. So the body weight is not exactly changed with the soda, this class of drugs, like lowering the glucose drugs. The second questions, based on our data on the immunohistostaining, we think the cell type in pancreas is on the tubular. I think it's the exocrine, the acinar cells, not in the islet, not in the beta cells or alpha cells. So we're still working on that.
Well, I would say that we certainly appreciate the work that you're doing. And this is a really exciting field, I think, for cystic fibrosis and cystic fibrosis-related diabetes both. If there are no more questions for Dr. Soon, we'd like to go ahead and move along to our third talk. Our third talk is the development of metabolic syndrome in a single center cohort after initiation of elexacaftor, tezacaftor, and ivacaftor. And this is by Dr. Gregory Ratai. And I think, with the advent of triple therapy, we're all very interested to hear more about this.
Hello, and thank you for listening to our session on emerging topics in endocrinology. My name is Greg Ratai. I'm an assistant professor of medicine in the Division of Pulmonary and Critical Care at UT Southwestern in Dallas, Texas. I'll be presenting our project on development of metabolic syndrome in a single center cohort after initiation of elexacaftor, tezacaftor, ivacaftor. I have no relevant disclosures for this presentation. For our outline, I'm going to briefly talk about the background, including weight gain and emergence of obesity, as well as the complications that come about with that, metabolic syndrome, its impacts on society, and then I will talk about our patients, methods, and results of our study. So with the increase in survival due to Cftr modulators, increasing recognition must be paid to the complications that come about with age, such as diabetes, osteoporosis, potentially metabolic syndrome. I bring this up because obesity is becoming a much more relevant problem in our CF population, and therefore we need to look into the complications that are related to this disorder. Weight gain with Cftr modulators has been well recognized since 2011, when ivacaftor was first used to treat patients with G551D. Over a 48-week study, patients increased their weight by an average of 2.7 kilograms for both adults, which is seen here and right, as well as children in the same time period. Weight gain was also seen with lumacaftor ivacaftor in patients who were homozygous for delta F508, in which over 24 weeks, their BMI increased by 0.24 to 0.28 kilograms per meter squared, and their weight increased by 1.23 to 1.57 kilograms. And this is seen in the transport and pooled figures down here from that study. However, with tezacaftor ivacaftor in patients who are heterozygous for delta F508 and homozygous for delta F508, there was not a difference seen in their BMI change. Weight gain was again seen with the addition of elexacaftor, and in patients who had at least one copy of delta F508, after 24 weeks, elexacaftor, tezacaftor, ivacaftor resulted in an increase in BMI of 1.04 kilograms per meter squared compared to placebo. And it wasn't just for patients who were previously on modulators. Those who were on tezacaftor, ivacaftor before, with the addition of elexacaftor, gained a BMI of 0.6 kilograms per meter squared, and their weight increased by 1.6 in a relatively short time period of just 4 weeks. With this weight gain, obesity is becoming much more relevant in our CF population, and this has been shown in several cohort studies. So in a group from the University of Minnesota, they showed 25.6% of their patients were overweight and 6.6 could be classified as obese. It's not just in the US though, because in a cohort from Italy, they showed that 22% of their patients could already be classified as overweight or obese. And this is reflected in the CF Foundation Patient Registry Annual Report from 2019, where it showed 23.1% of patients were already overweight, 8.3% of them could be classified as obese, and we can compare this to 1999, where only 13% of patients could be classified in either one of those categories. And I included this figure from the annual report as it shows that over time, the BMI for both men and women is steadily increasing. With obesity comes other complications such as hypertension, which we have traditionally not thought to be a problem. However, in the 2019 report, 6.4% of patients over the age of 18 were said to have hypertension. This is similar to the rates of osteoporosis and hemoptysis, which get a lot more attention in our overall clinical practice. Hypertension is also seen in those cohorts that I mentioned. So from the University of Minnesota, the prevalence of hypertension was 31% in overweight patients, 25% in obese patients, compared to just 17% in those with normal weight. In a separate series from Montreal, weight and blood pressure tended to correlate very well. And so patients who were overweight had significantly higher blood pressures than those with normal weight and underweight. However, all of these blood pressures were in the normal range. And in that Italian series I mentioned, hypertension was present in 12.7% of their overweight patients, which is twice as high as the general population reported in the US. Along with hypertension, we have to look at other cardiovascular complications, such as hyperlipidemia, although this is not even asked about in the CF patient report questionnaire. So in a separate series from Montreal, they showed that 23% of the patients had low HDL, 9% had hypertriglyceridemia, and 4% had mixed dyslipidemia. And in the cohorts from Minnesota and Montreal that I mentioned before, being overweight and obese tended to have a significantly higher total cholesterol, significantly higher LDL, and in the Minnesota group, a significantly lower HDL. One complication that we're all very familiar with is CF-related diabetes. And in 2019, in the CF patient registry report, 31% of adult patients were reported to have CFRD. This is important because CF-related diabetes is associated with increased mortality and a faster yearly decline in FEV1 than those with normal fasting glucose. And as we can see in the figure from the right, the incidence of diabetes tends to increase with age and doesn't start to go down until our total number of patients start to decline as well. Other complications of CF-related diabetes include microvascular complications. And in a study that compared CF-related diabetes to type 1 diabetes with matched controls, there were similar rates of neuropathy and nephropathy, though the numbers were low. CF-related diabetes had lower rates of retinopathy compared to type 1 diabetes, but in a series from Wales, 43% of their patients screened had retinopathy. The macrovascular complications are unknown, but this is likely a function of our young population. Switching gears, I'm going to talk about metabolic syndrome, which is a constellation of metabolic risks for type 2 diabetes and cardiovascular disease. This was first defined in 1999, so the most accepted definition is the National Cholesterol Education Program, which was published in 2001 and revised in 2005. To meet the diagnosis of this syndrome, you have to have greater than or equal to the 3 of the following: fasting glucose greater than 100, HDL cholesterol of less than 40 for men, less than 50 for women, triglycerides of greater than 150. Obesity is defined by a waist circumference of greater than 102 centimeters for men, greater than 88 centimeters for women, and hypertension is defined by blood pressure of greater than 130/85 or on therapy. Metabolic syndrome is very common, and in the US, 35% of patients can be classified as having metabolic syndrome. And it's a well-known association with cardiovascular events and death. And in a meta-analysis, the relative risk of cardiovascular events and death was 1.78 compared to matched controls. But it's not just cardiovascular disease. It's also associated with liver disease, which is very important for our population. And in a meta-analysis, 1.5 million patients, it showed an increased risk of liver-related events with metabolic syndrome, which is cirrhosis, liver-related death, and stage liver disease. And a prospective study following 4,400 patients, the development of metabolic syndrome was associated with development of non-alcoholic fatty liver disease. Metabolic syndrome is also associated with an increased risk of CKD and microalbuminuria, which has been shown in both a cross-sectional study and a prospective study that followed patients for 9 years, which showed higher rates of CKD in those patients who developed metabolic syndrome than those who did not. This brings us to our study. And so the idea behind that is with the approval of triple therapy, weight gain and obesity will likely become more apparent, and therefore adverse syndromes associated with that, such as metabolic syndrome, may also arise. We need to recognize these early to prevent long-term complications as our life expectancy improves for our patients. So for our patient population, we use patients seen at the UT Southwestern Adult CF Center. We collected data from November of 2019 to March of 2021. To be included, it was very simple. You just had to have a diagnosis of CF with regular follow-up and started on triple therapy. To be excluded, we had to lack baseline or 1-year data or not be on therapy for 1 year. We also did not include patients who were just on lumacaftor or just on ivacaftor prior to starting triple therapy, as the numbers were very small. So we had 303 patients who met inclusion criteria over the study period. We excluded 203 of them due to missing 1-year data. Of the 100 patients who met inclusion, 48 of them were transitioned from tezacaftor to ivacaftor. 8 of them were transitioned from lumacaftor to ivacaftor, and 44 patients had not been previously on modulator therapy. The variables that we collected were age, gender, race, height, weight, BMI, blood pressure, waist circumference, labs, prior modulator use, CFTR mutation, and FEV1. We compared these for baseline in 1 year. Our primary outcome of interest was development of metabolic syndrome at 1 year. Our secondary variables of interest were change in the individual characteristics, which resulted in metabolic syndrome, effect of prior modulator therapy on development of metabolic syndrome, and our change in weight and BMI over time. For our patient demographics, We had an equal number of men and women. Our average age was 30.5. We had mostly Caucasian, mostly patients with pancreatic insufficiency. We had just over a third of our patients with CF-related diabetes. At inclusion, 5 patients had already met criteria for metabolic syndrome. Our mean BMI was 22.2, our mean weight was 62.7, and our average FEV1 was 61.6. For statistical analysis, because we had paired dichotomous variables, we used the Maximar test to compare our primary endpoints as well as secondary endpoints involving prior modulator use. We used a chi-square test to also analyze the effects of prior modulator use, and we used an ANOVA test to compare baseline and 1-year characteristics for development of metabolic syndrome. So comparing baseline to 1 year, our age increased by 1.1 years. There was no difference in the number of patients who are pancreatic deficient or with diabetes. We had a statistically significant increase in the number of patients with metabolic syndrome from 5 to 16. Our mean BMI went up by 1.3, weight increased by just over 4 kilograms, and our FEV1 increased by just under 10%. These bottom 3 rows were not analyzed for significance as they had such high standard deviation. Using the Maximar to compare prior modulator use, this figure on the left, we looked at tezacaftor, ivacaftor triple therapy. There were 46 total patients in this series. This box in the upper left shows that there were 39 of these patients who did not have metabolic syndrome at enrollment and remain free of metabolic syndrome at 1 year. There were 4 patients who had metabolic syndrome at enrollment and still had metabolic syndrome at 1 year. And in the upper left, there were 3 new patients with metabolic syndrome. And so this was not significant based on the Maximar test. However, going from no prior modulator use to triple therapy, there were 41 total patients. 5 new patients developed metabolic syndrome. 35 patients remained free of metabolic syndrome, and there was 1 patient at enrollment. So this was statistically significant. However, when we looked at all 3 groups together and using the chi-square test, we did not find a statistical difference. Looking at characteristics resulting in metabolic syndrome from baseline to 1 year, we did not have a change in the number of patients with diabetes. The number of patients with hypertension went from 11 to 21. Our HDL did not change over time. The triglycerides increased by just under 20 milligrams per deciliter, which just missed statistical significance. And our waist circumference increased by 1.2 inches or 1.5 inches, but did not meet statistical significance. So in conclusion, 1 year after initiation of triple therapy, there's a significant increase in the incidence of metabolic syndrome in our patient population. There was no difference in development of metabolic syndrome, whether you are on a prior modulator or not. And there does not appear to be one driving characteristic which results in metabolic syndrome. This makes it challenging as it does not provide us with a group at most risk or a characteristic at most risk that we can target for intervention to prevent development of this syndrome. The strength of our studies is prospective, starting at the time of initiation of triple therapy. This allows us to do additional analyses and subgroup analyses. And it's an enrollment of a real-world population of patients, as we did not control what they ate or drank after they started triple therapy, so it's very generalizable. Our limitations are that it's observational, so it doesn't prove cause and effect. We have a small number of patients and a short duration follow-up. That being said, though, we plan to follow our patients for a total of 5 years. We will continue to enroll patients as they're started on elexacaftor, tezacaftor, ivacaftor. We plan to further break down our analysis by gender, as this was not separated in the initial study. And then we plan to follow our patients to develop metabolic syndrome for development of complications such as cardiovascular disease, liver disease, and renal disease. One question that this brings about is, should we be including questions for metabolic syndrome on the CF patient questionnaire, registry questionnaire, to help detect these patients early and prevent complications? I would like to say a special thank you to David Finkley, who was the original who had the original thought for this plan and this project and served as my mentor throughout. Ali Rustroff, who was a resident who helped a lot of data collection. She's now a fellow up in Kansas. Raksha Jain, who is the director of our adult CF program at UT Southwestern, who has served as a mentor throughout my early career. Joan Reich, who did our statistical analysis and helped with analysis of our data. The UT Southwestern Adult CF Center staff, who help collect a lot of these clinical data and helps take care of all of our patients and provide excellent care. And then our patients, because without them, none of this would be possible. Thank you very much for listening. Here are my references. If you have any questions, please feel free to ask.
Thanks, Dr. Raitai. That was awesome. I've done a lot of talking with my colleagues about how the advent of triple therapy may change the metabolic profile of our patients and the way that we treat them, preventing long-term comorbidities and problems that they might encounter. There have been a few questions that have come in from our co-speakers who were wondering specifically about hypertension. Dr. Lee was wondering, what do you think drives the hypertension following the initiation of triple therapy? And Dr. Soon was wondering if you thought that the hypertension related to the epithelial sodium channel level. So I think if you could address a little bit about the hypertension that is occurring, that would be of great interest to our audience.
Sure. So I'll be honest, I don't know about the ENAC channel, and I think it's not well studied at this point. And certainly hypertension is something that is emerging amongst our patients. Since, as I mentioned, it's really only a minority, only about 6% of the adult population. And then the pediatric population is even less than that, less than 3%. So I think there's still a lot of research that needs to look into that, specifically the ENAC. In the New England Journal paper that looked at addition of elexacaftor to patients with delta F508, they did see a slight increase in patients' blood pressure by about 4 millimeters of mercury. So it wasn't enough to put them into the hypertension. I think some of that is believed to be just to higher salt retention that's related to the adding triple therapy to patients, though I don't think anyone has really been able to nail down a mechanism to this point, and still needs to be investigated further.
Great, thank you for that. The next question is, based on your data, how should CF centers screen for metabolic syndrome and how frequently, and what age should we start at?
So I think the biggest goal of our project looking into this was to really bring awareness to this problem that's starting to come about. And we, in our adult center, we actually started to see particularly patients who were on medications that were associated with weight gain, such as some of the second generation antipsychotics that they got put on for depression. We started to see a huge weight gain in those patients once they got started on triple therapy. And so we started to increase our kind of screening for these patients, particularly with waist circumference and looking at their lipid panels earlier. So we do this at least once a year at our center, which I think is a reasonable approach. And I think as patients get started younger, it may just be part of our yearly vitals that we check on our patients in terms of waist circumference, lipid panels, things like that, to make sure that we detect these early, because we don't know what's going to happen in 15 years from now as patients are getting older. And many of our patients don't have the best health habits anyways. And so they're eating high calorie diets, high fat diets. And so that may, down the road, as our patients get older, we start to see a lot more complications with that. And so our goal is just to bring awareness to that at this point.
Yeah, certainly in pediatrics, we have been discussing a lot about how we counsel our young patients, because we used to counsel, obviously, very high calorie diets. And with the advent of earlier introduction of triple therapy, that may change because that might not be as needed anymore. And so, like you said, I think time will tell. And the first cohort of patients may teach us a great deal about that. Our next question is, did you look at any differences between those excluded for the missing data and the cohort with the full data? Because your excluded bunch was bigger than the included cohort. And will you be able to go back and include some of those subjects in the future, do you think?
Yeah, so our goal is actually to, because we knew that we wouldn't have a full, all of our patients at 1 year. So this was sort of just our first round of complete data. And so our goal was actually to follow these patients for the next 5 years as they start Trikafta and are enrolled at a year, and then continue that over time. Because a lot of the studies looking at weight gain over a year, 48 weeks, their weight BMI increase tended to plateau a little bit. And so we're not sure if we're going to see that in our study. And particularly a lot of these like development of metabolic syndrome, development of CF-related diabetes, all of these things increase with age. And so as our patients age, as they become more at risk for these other complications, I think we'll see more and more metabolic syndrome. And so we had built into our design to follow these patients, and this is just our initial data that we were able to pick up from those. So I think, yes, we'll see more numbers, but we didn't compare yet the missing data set versus the not set.
Excellent. And then Dr. Hall has a question. And if I'm not mistaken, I think she's the doctor who runs the lab with Dr. Castillo. And she says, I may have missed this, but did the increase in metabolic syndrome occur primarily in your population with pre-existing CFRD? Or do you have the power to determine that? And can you speculate whether the emergence of these features might change the management of CFRD patients on modulator therapy?
So we didn't look specifically at the patients who already had CFRD. That was about a third of our population. And so, but I do think that's an interesting thing to look at, and I don't think that we actually thought about that. So I appreciate the insight. I think that having CF-related diabetes is associated with known microvascular complications. We know in general patients with diabetes, they have macrovascular complications. So potentially we may need to be more aggressive with screening those patients and detecting them earlier so that we can make interventions, say if they have derangements in their lipids, maybe they need to start statins, which is something that we really haven't needed to do very much in our patient population. But certainly knowing that they already have complications like type 1 diabetes, maybe we need to be more aggressive about managing those risk factors for them as well.
And finally, have you changed your nutritional advice to patients based on your results?
Yeah, so we have been selecting those patients that we've noticed have gained a lot of weight, and we try to intervene early on them to counsel them on more kind of healthier lifestyle choices, healthier diet. This has allowed us to select those patients that we're seeing trending in the wrong direction from a weight standpoint early on. And we do have a dietitian in our clinic who meets with our patients at every visit to help out with that.
Wonderful. I think with that, we're wrapping up our questions for you. That was a great talk. And so I'm going to move on to our next talk, pregnancy and outcomes in the era of CFTR modulators and the COVID-19 pandemic. And this talk is given by Dr. Susan Lee. And I'm just going to introduce her because she did not include her introduction at the beginning of her talk. She is an assistant professor of clinical medicine at Ohio State College of Medicine. She's an adult CF provider at Nationwide Children's, and she's also a primary care physician in internal medicine and pediatrics at Ohio State University Wexner Medical Center. So with that, we'd like to open up with her talk.
Hey everybody, thanks so much for coming. Today I'm going to be sharing with you our center's unique experience with pregnancy over the past year. I have no conflicts of interest to disclose. So as a single center, we saw a large increase in fertility after Trikafta was approved. Just from March of last year to March of this year, we had a total of 18 pregnancies. And of these, 14 women gave birth to 15 babies, including a set of twins. This represents a 16% pregnancy rate for our women of childbearing age, which is much higher than what was last reported nationally at 2.5%. However, as you know, CF patients are at higher risk for complications of pregnancy compared to the general population, including maternal death, pre-gestational diabetes, gestational diabetes, preterm delivery, and C-section. So due to this rapidly growing population, we quickly realized that we needed to develop a uniform and multidisciplinary approach to prenatal care. So we formed what we call a pregnancy task force, which comprised of our internal core multidisciplinary CF team, as well as multiple external collaborators, with the key players being MSM and endocrinology. We met every other week to discuss our pregnant patients and learn from our collective experience. And we aim to see these patients 1 to 2 times per trimester. So throughout this, we learned many lessons, which I will share with you today. But at the core of what we learned is the need to empower the patient to take care of her own health by providing her with the knowledge and education about her pregnancy. So we tried to identify patients in the preconception stage and provided early linkage to genetic counseling and for visits with high-risk OB. We also specifically scheduled each patient for a preconception visit with us at the CF clinic. And this is where the bulk of the educational process took place. We would help them understand all of their risk factors going into pregnancy and help them to understand that because of this, they are going to be experiencing perhaps the highest burden of care in their lifetime in the upcoming months, which I think is particularly important to tell patients up front, especially in the age of Trikafta, where many patients have been experiencing a de-escalation in their burden of care. We also try to anticipate some of the challenges and points of confusion that we identified along the way. The main one being the difference in screening and management of gestational diabetes. So here are the risk factors we primarily worked on. So for advanced lung disease, we aim to have updated hypoxia screening. For those with baseline, low BMI or no nutritional deficiencies, we aim to optimize these as early as possible. For everybody with baseline CFRD or impaired glucose tolerance, we refer to endocrinology for a continuous glucose monitor and consideration for insulin therapy. For everybody with baseline mental health disorders, we attempted to provide early intervention and ongoing close monitoring. And then due to the nature of multiple high-risk medications, a thorough medication reconciliation was done. And during that, we talked to the patients about the risks and benefits of Cftr modulator use during pregnancy. We switched everybody from 2 CF vitamins to 1 CF vitamin plus a prenatal. And then we provided education on common antibiotics that they may be used to taking for CF exacerbations that would need to be avoided during pregnancy, including tetracyclines, Bactrim, Cipro, Levaquin, and linezolid. And then some other commonly used CF meds, they were generally continued, including inhaled antibiotics, azithromycin, H2 blockers, PPIs, and montelukast. And then for intranasal steroids, we recommended patients use the lowest effective dose. For antihistamines, we generally preferentially switched to loratadine and cetirizine. So looking at our overall outcomes, of the 18 patients who became pregnant, 17 were on Cftr modulators, and the overwhelming majority of which was on Trikafta. And despite the fact that these pregnancies occurred at the immediate onset of the pandemic, our patients did very well from a pulmonary standpoint. Only 3 patients required PO antibiotics for exacerbations. 1 was admitted for IV antibiotics, but actually had COVID. And then while there were 4 admissions during pregnancy, only 1 was for a pulmonary exacerbation. Of the 18 pregnancies, 14 women delivered healthy babies. There was 1 elective termination and 3 miscarriages. All the miscarriages occurred within the first trimester, except for 1, which was in the second trimester, but was due to complications from a cerclage placement. And so overall, this represents a very similar miscarriage rate to that of the general population. Now, specifically looking at COVID-19 data, 3 of our women were infected with COVID, and 2 of the 3 had advanced lung disease, and only 1 required admission. This admission rate at 33% is very similar to national data of about a 42% hospitalization rate. We had 1 miscarriage within this group. However, this patient was incidentally found to have COVID-19 during a pre-op screening for a cerclage placement for cervical insufficiency and was actually completely asymptomatic. Her miscarriage was due to complications of the cerclage placement itself. The other patients with COVID-19 did not appear to have any adverse fetal outcomes, although this data predates our current Delta variant surge. So unfortunately, we observed a very low COVID vaccine rate, and this may be in part due to the fact that COVID vaccine was not actually available for many of our women during pregnancy. However, even in this postpartum period, we still have not seen an increase in vaccination rates, despite increasing literature supporting the safety and efficacy of the mRNA vaccines during conception, pregnancy, and breastfeeding. So looking at our advanced lung disease population, we had 3 patients, or 17%, with advanced lung disease, which we defined as an FEV1 of less than 40%. Our general approach was to ensure that everybody had a baseline hypoxemia screen. And then we repeated the screening late in second trimester, or basically as the uterus became more gravid. We adjusted oxygen for a goal stat of greater than 92%. Now, all 3 of our patients did require an increase from baseline oxygen use during pregnancy. And then we switched everybody to a RAP vest, generally in the third trimester to accommodate for the growing uterus and the expanding rib cage. We had 2 patients with pulmonary hypertension, and after discussion with their cardiologist, both of their pulmonary vasodilators was discontinued during pregnancy and restarted in the postpartum period. In terms of pulmonary exacerbations, no one required PO antibiotics. We only had 1 patient require IV antibiotics, and she actually had COVID. We had 2 patients admitted. One was for the COVID admission, and a second was due to dyspnea from a gravid uterus, as she was actually pregnant with twins. So overall, the rate of IV antibiotic use was roughly 0.04 per month, which is about the same as what is reported in the literature for non-pregnant patients with advanced lung disease. So this suggests that with appropriate supportive management, patients with advanced lung disease are not at increased risk for pulmonary exacerbations during pregnancy, and their increased rate of admission is primarily related to extra-pulmonary disease or pregnancy itself. Now, turning our attention to those with CFRD, 8 or 44% of our women had baseline CF diabetes. 1 had an elective termination, and so she was excluded from the rest of this data. But of those that were presented here, there was a 0% miscarriage rate, which is significantly lower than that of the general population of about 30%. All of our patients were referred to endocrinology immediately and placed on a continuous glucose monitoring for closer monitoring during pregnancy. Patients were managed primarily by a combination of either basal bolus, insulin, or mealtime insulin alone. Although we did have a minority that were also managed through just basal insulin alone without any hypoglycemia issues. None of our patients, unfortunately, about 38% of our women still did not meet weight gain goals despite diligent adjustments in insulin therapy and intense nutritional counseling. None of our patients had issues with hypertensive disorders of pregnancy. And then when you compare these outcomes to the general population of gestational diabetes, we observed a markedly lower incidence of C-section, miscarriage, and preeclampsia. Now, when you look at fetal outcomes of CFRD pregnancies, we had a 50% incidence of preterm delivery, which is higher than in the non-CF pregnancies. However, this number is slightly skewed because we had 1 set of twins, and if you count them as 1 baby, our incidence is actually around 40%. Other complications, including LGA and hypoglycemia, were relatively low compared to the non-CF pre-gestational diabetes pregnancies. 38% of our infants went to the NICU, but all were related to complications of premature delivery rather than hypoglycemia. So again, when you compare this to other pre-gestational diabetic pregnancies, we observed a lower incidence of LGA and hypoglycemia. Turning our attention to gestational diabetes, this probably represents one of the biggest hurdles and sources of confusion that we faced. And this is primarily due to the differences in gestational diabetes screening for CF versus non-CF patients. So the CF Foundation recommends a 2-hour 75-gram screen to be done in the first trimester, second trimester, and again in the postpartum period. However, for the general population, unless the baseline A1C is greater than 6.5%, gestational diabetes screening does not actually occur until the second trimester through a 2-step approach with a 50-gram followed by a 100-gram challenge. And so through this process, we identified 4 women with gestational diabetes, but due to the differences in screening, one of our patients actually had newly diagnosed CFRD just before she got pregnant, and she did not get a chance to get started on insulin. But because her first trimester A1C was less than 6.5%, she was missed in the screening process and actually managed as a gestational diabetic and had at-goal glucoses. However, she ultimately had severe pre-E develop around 36 weeks and had an emergency C-section due to this. And so, despite our best efforts and close communication with maternal fetal medicine, screening for gestational diabetes remains a huge challenge in our patients. And, overall, we had 4 patients get diagnosed with gestational diabetes. Of this 0% miscarriage rate, very interestingly, 100% of our patients who developed gestational diabetes had baseline impaired glucose tolerance, and 100% of our patients with baseline impaired glucose tolerance developed gestational diabetes. And this is part of the reason why we uniformly referred everyone with baseline impaired glucose tolerance to endocrinology at the onset of pregnancy. Now, 100% of our patients were managed conservatively rather than through insulin with in-range glucoses. However, dietary guidance in gestational diabetes is the other major challenge. At our center, any mom who's identified as gestational diabetic automatically receives a protocolized call regarding calorie restriction and carb control. So our dietitians needed to spend many hours of their lives really trying to correct this confusion for patients. We only had one patient with preeclampsia, and she was the one who was mislabeled as gestational diabetes when she actually had CFRD. In terms of the subsequent risk for developing CFRD, we were only able to get the postpartum OGTTs done about half of our patients. We found that moms were just very busy and rightfully very overwhelmed, and they really just didn't have time to come in to do their postpartum OGTT. Now, specifically looking at the fetal outcomes, again, we had a 0% rate for LGA and hypoglycemia, which is lower than the general gestational diabetes group. Mental health was our other big challenge. 74% of our patients had a baseline mood disorder. However, 64% of them declined linkage to additional mental health resources during pregnancy. And then even in the postpartum period, we were again unable to complete postpartum screening for about 50% of them. So overall, due to the large pregnancy volume we saw, we learned a lot of lessons. First, given the high complexity level of these patients, a multidisciplinary approach is definitely needed. And as I have hopefully convinced you, helps to improve outcomes. However, despite relatively heroic efforts, many challenges remain. I think one of the biggest challenges is the extremely high burden of care that these patients experience during pregnancy. We observed moms finding themselves needing to prioritize certain aspects of their care above others. So this means their mental health during pregnancy, and then in the postpartum period, just general poor follow-up. We try to alleviate some of this burden by using telehealth, which 100% of our patients utilize. However, very clearly, this still was not enough. A second major challenge we identified is the differences in the screening and management of gestational diabetes. At the end of the day, CF represents only a very small portion of the patients seen by OBGYN, and it is very hard for them to remember these nuanced differences in gestational diabetes screening guidelines. And as such, we feel that the most important thing that we can do for our patients is to educate her and teach her about these differences up front. So that we can try to eliminate as many sources of confusion as possible and really help prepare her for what is to come, not only for the next 9 months, but for in the postpartum period as well. I'd like to give a huge thanks to our team who helped to make this possible. All of the CF docs, nurses, dietitians, pharmacists, mental health coordinators, and our genetic counselor. I would also like to give a huge thanks to our external collaborators who took excellent care of our patients during pregnancy and remained so patient with us as we learned how to care for this growing population together. And with that, I leave you this picture of the most recent mom who had just had her baby, and I will take any questions.
Thank you so much, Dr. Lee. I think this is a really important new frontier in cystic fibrosis care. While we've had, several pregnant patients in the past, now a lot of patients are really thinking about family planning, and our centers aren't necessarily set up for this multidisciplinary care. I think it's really interesting that you are internal medicine and pediatrics, and you're involved in the care of pregnant patients. Can you expound a little bit on who runs this program? Who's at the head? Who directs the care and coordinates the care in your program? And how did you set up the multidisciplinary aspects of your program?
Thanks so much for your question. So, I think honestly, this is such a big team effort. I think the physicians try to guide aspects of it, but it's completely a multidisciplinary effort. The whole idea came about because of our dietitians, actually, because they've always noticed historically during pregnancy that the gestational diabetes screening was very confusing, and there was not really a uniform approach to management of CFRD. And we had issues with weight gain previously for our pregnant patients. So they really, once we started to see this boom, they were the ones who really wanted to make sure that our patients were well taken care of. But I think we kind of each have our own little box and corner, and we try to meet every other week or so to kind of talk through what the newest issues that we're finding are.
And along those lines, one of our viewers asked, do your dietitians, the CF dietitians, I think they mean, attend the gestational diabetes clinic to liaise over the CF appropriate diets? This questioner actually found that useful in their own program.
Yeah, so I think one challenge is that our center is still at the Children's Hospital, and then all of our adults for their prenatal care are having to go over to the adult hospital over at OSU, so that we're not physically in the same location. But because of all the challenges that we continue to find, like where all our gestational diabetics routinely just got that same talk from our maternal fetal medicine folks, we've actually since revamped the process so that our dietitians are the only ones who are going to be doing dietary guidance for those patients after they get diagnosed.
And a couple of nuances. One of our viewers, Lynn Fries, she comments that her high-risk OBs want the pulse ox 95% minimum. What are your comments about that?
Yeah, so actually our high-risk OBs want the same thing. And we actually, there's not great data looking at specifically, they were all the guidance on keeping the stats above 95% came primarily from like acute respiratory issues. And, they had pneumonia, ARDS, and some other types of pulmonary infections, but there wasn't really a lot of data guiding what to do for chronic lung disease. And some of our patients were at baseline already on 3-4 liters of oxygen, and during pregnancy, to have them on 5-6 and to continuously go up was very, very challenging for those patients. So we sort of, after talking with maternal fetal medicine, felt like these patients have chronic lung disease. And so hopefully the fetus has already adapted to that slightly lower oxygen saturation. And we found that our outcomes by just adjusting to 92% were fine. And, honestly, we could not find really any data to guide specifically, 92 versus 95% either way. So that's where we kept it.
And how many of your mothers continued modulators during pregnancy and breastfeeding?
Yeah, so all of our mothers remained on modulators during pregnancy. There was one mother who came off briefly for like a few months, and then she actually decided to go back on it because she just didn't feel as good and had lower energy off of it.
Yeah, I think that's been our center's experience too, is that these mothers are getting pregnant because they feel so good, on the modulators and aren't really wanting to come off of it. How many of your moms are breastfeeding, and are there challenges or successes with that?
Yeah, interesting point. So that is definitely something we are currently looking at. So I believe we have had 6 mothers attempt to breastfeed, and we've had, we haven't had like any babies make it to, a full 12 months of life yet. But a lot of women I find stop after the first few months. There generally can be issues. There's a lot of issues with like just sufficient breast milk supply. And, is that because they just would need to eat such a high calorie diet that it's really not possible for them in that postpartum period? Or like, are they so busy between managing their CF and, a newborn that they really just don't have time to keep up with needing to continuously empty or working on breastfeeding, which, at the end of the day is breastfeeding is very, very challenging.
Another one of our viewers says, thinking about the presentation on hypervitaminosis A with highly effective modulators, are you and your center thinking about monitoring vitamin A more closely in pregnancy?
Yeah, so that's a great question. So we generally, like, now whenever we find that patients are thinking about getting pregnant, or even in that preconception stage, we pretty much update their vitamin levels and try to get a baseline of where they're at. And that's part of the reason why we switch everybody away from the 2 CF vitamins and over to a prenatal, is to account for the extra vitamin A that's found in the CF vitamin.
And personally, for me, cystic fibrosis related diabetes is always on the front of my mind. So you had talked a lot about the challenges with gestational diabetes screening, and what other differences have you noticed with this population and in regards to these kinds of screenings and things?
I think the biggest challenge that we've noticed is just the difference in the way that the screening is done. So between all of our patients, some of them, were screened with the 2-hour screening recommended by the CF Foundation, but a lot of them were done with the 50 and 100 that the general population does. We've noticed, which especially with the 3-hour 100 gram screen, we've had a large amount of patients get hypoglycemic from it, which so since we have been talking with our maternal fetal medicine folks, and we've actually revamped our system where everybody with a baseline impaired glucose tolerance now automatically basically gets treated as a gestational diabetic from the beginning, and they get screened as if they've had prior gestational diabetes. So if they are at OSU getting screened, they would be getting the 3-hour screen from the beginning. And then we just try to educate patients that they might get hypoglycemic and to kind of watch out for that. But it's very, I think the differences in where we get the data, it makes it very challenging to sort of know, are we potentially missing some gestational diabetics because of that?
Another viewer says, I may have missed it, but are you using continuous glucose monitoring throughout pregnancy to help glucose control and nutrition? We found that it reduces maternal anxiety.
Yes, definitely. So all of our CFRD patients, we have moved on to a continuous glucose monitor during pregnancy, and they all have uniformly loved it. Now, obviously, depending on insurance coverage, some of them may be getting a continuous glucose monitor that's a little bit more painful for them. But, we're certainly trying to get everybody on a well-tolerated glucose monitor. We actually try to do this for our gestational diabetics as well, but obviously there's a lot of insurance coverage criteria that they don't meet. But we were, I don't think we were able to successfully get any of them on, but we tried for all of them.
Yep, definitely. In my center, I manage the diabetes, and because I can call a lot of them cystic fibrosis related diabetes, or sometimes pre-existing diabetes non-specified, I can get CGMs where my maternal fetal medicine colleagues have been unsuccessful because of coding. But that's definitely been a challenge at my center as well. And then one more question. At what point do you provide preconception education? When they express desire to get pregnant, or for everybody not using birth control?
Probably should be the latter. Honestly, probably should be. But we're doing it primarily whenever, like, if somebody tells us that they're thinking of getting pregnant, within the next, year or so, or that they're, or next few months, that's when we actually schedule them for their preconception visit with us and talk about all those things. Because we find that it honestly takes like a few months to really get the process rolling for them and help them to understand everything, get the genetic counseling done and everything.
And do you do that primarily with the CF team or primarily with OB?
Yes, so that is done by the CF team. Yes.
And do you ask at your annual review whether they're planning on a pregnancy in the next year?
So our nurses have been really great about asking that pretty much to all of our patients, and they're the ones that alert us to it when they see it or hear about it.
Another viewer asks, do you pay any special attention to bone health for these patients?
That's a really great question. We have not focused on that so far. I think bone health, especially with the fact that I think a lot of patients receive zoledronic acid, has, especially with it regards to pregnancy, has been a topic that we have discussed a lot at our center. And just kind of, I guess, off the beaten pathway, we have been trying to limit how much our women of childbearing age get bisphosphonates by we'll probably give them like a dose of Reclast, and then we'll just keep monitoring their DEXA scans serially. And as long as it doesn't change, we have just kind of kept them off of it because of the reproductive potential.
Barbara Butera says, and patients get counseling when they start Trikafta that they're more likely to conceive.
Yes.
At most centers. And I would say, my OB girlfriend always says, if you ain't stopping it, you trying. So I think, in teens, I always keep that in mind. Yeah. I think that probably concludes the questions for you. Thank you for that wonderful forward-looking talk. We're going to move on to our last talk in this great session. We're going to talk about testosterone deficiency in men with cystic fibrosis, understanding the prevalence and association with clinical outcomes. And this is going to be by Dr. Puri.
Hi there, and thank you for joining me for today's presentation. My name is Neha Puri, and I'm a third-year internal medicine resident at the University of Toronto. And the title of my presentation is Testosterone Deficiency in Men with Cystic Fibrosis, Understanding Prevalence and Association with Clinical Outcomes. I'd like to thank Dr. Julie Gilmore, Dr. Elizabeth Toulis, Dr. Adam Miller, and Jenna for their collaboration on this project. I have no conflicts to disclose, and my objectives for today's presentation are the following. Understand how testosterone deficiency is diagnosed, differentiate between primary and secondary hypogonadism, understand the prevalence of testosterone deficiency amongst male patients with cystic fibrosis at our Toronto CF clinic, and examine the relationship between testosterone and important clinical CF characteristics. So let's think back to medical school and review the normal hypothalamic pituitary gonadal axis. So we have our hypothalamus, which secretes gonadotrophic releasing hormone, more commonly known as GnRH, that works on our pituitary gland, which then releases follicle stimulating hormone, also known as FSH, and luteinizing hormone, better known as LH, which then works on our testes, on our Sertoli and Leydig cells to help make testosterone. And testosterone itself negatively feedbacks at the level of the pituitary and the hypothalamus. Now, what happens in hypergonadotrophic or primary hypogonadism? Well, this is a failure at the level of the testes. So in this case, because the pituitary gland is still intact, your LH and FSH values will be high, whereas your testosterone will be low. Now, what causes this? Genetic abnormalities such as Klinefelter's, testicular trauma, chemotherapy, local radiation, or orchitis. Contrarily, in hypogonadotrophic or secondary hypogonadism, this is a failure at the level of the pituitary or the hypothalamus. In this case, your LH and FSH values will be low, whereas your testosterone values will also be low. Common causes of this include chronic illness, pituitary lesions, iron overload syndromes, anabolic steroids, glucocorticoids, and severe obesity. And I'll make note again of the glucocorticoids because, again, our patients with cystic fibrosis are often on prolonged courses of steroids as well. Now, let's think about the literature of hypogonadism in male patients with cystic fibrosis. There actually isn't much. In 2000, Elkin, in their study, looked at 126 male patients with cystic fibrosis, and they found that low total testosterone values were observed in up to 45% of patients, and low free testosterone values in 36% of patients. Now, in a few slides, I'll help you differentiate the difference between free and total testosterone. Similarly, in the 2003 study by Lafiki, they compared 40 male patients with cystic fibrosis to 23 age-matched healthy counterparts and found a statistically significant reduction, again, in the total testosterone levels amongst those with cystic fibrosis. Well, now let's take a moment to think about the clinical symptoms of testosterone deficiency, which can be very non-specific, truthfully. From a psychiatric perspective, they can present with low mood, depression, sleep disturbances, poor concentration. From a reproductive perspective, decreased libido, erectile dysfunction. And from a physical perspective, delayed or incomplete sexual development, loss of body hair, decreased muscle bulk, gynecomastia, or osteoporosis. Now, with regards to osteoporosis, the osteoporosis fractures in men's study actually found that patients with low testosterone had reduced bone mineral density in the hip. Now, the hip bone is primarily cortical bone, although it does have some trabecular bone as well. And I mention this specifically because I'll tie this back in as we talk about the results from our study later in this talk. Now, how does one diagnose testosterone deficiency? Well, the Endocrine Society recommends obtaining 2 low morning fasting testosterone values in addition to the presence of clinical symptoms. Now, why morning and why fasting? Well, testosterone values have a diurnal pattern, as you can see in the graph on the right-hand side of this slide, peaking in the morning and are also impacted by glucose intake. Now, realistically, I understand this could be hard to actually, feasibly do in the clinic setting itself. Now, earlier in my presentation, I mentioned that there was a difference between free testosterone and total testosterone. So let's talk a bit more about that. Well, we have a protein called sex hormone binding globulin, also known as SHBG, which is a protein that is produced by the liver, and it transports testosterone in the blood as an inactive form. And that can make up about 45 to 60% of our testosterone. We then have our free testosterone, which is not bound to anything. That makes up a very small proportion of 2 to 3%. And then we have our albumin-bound testosterone, which makes up about 30 to 45. If you take our albumin-bound testosterone in addition to our free testosterone, that makes up our bioavailable testosterone, which means that it's readily available to our cells to use. If you add all 3 of them up, that makes up our total testosterone. Now, where the problem occurs is that many things can impact your SHBG level, which can thereby impact the amount of testosterone that is actually readily available to us. Total testosterone measurements do not distinguish between what's readily available and what's not readily available. Now, what impacts SHBG? Well, some conditions which decrease it include obesity, diabetes, steroid use, hypothyroidism. Contrarily, conditions that increase it include age, cirrhosis, hyperthyroidism. Bottom line, our patients with cystic fibrosis, they often have significant comorbidities, some which are listed above, which can impact SHBG, and therefore bioavailable testosterone may actually be a better representation of gonadal status because it represents the testosterone that is actually readily available to cells. Now, bioavailable testosterone can be measured in 2 ways, a direct way or an indirect way. At our Toronto CF clinic, it's actually measured in a direct way using an radioimmunoassay, whereas it can also be measured in an indirect way where you measure the total testosterone value, the SHB value, and then you subtract the 2. So one of the strengths of our clinic is that we actually measure it in a very direct way as well. Now that we have some background, let's talk about our study actually. So our study, the aim includes to characterize the prevalence of biochemical testosterone deficiency and examine the relationship between testosterone levels and important clinical characteristics and patient outcomes. This is a retrospective 3-part study. There are 450 eligible patients. Ultimately, we include 345 adult male CF patients with over 1,600 unique testosterone measurements. And these are all patients who attended our CF clinic between January 2009 to October 2018. Our inclusion criteria was male patients over the age of 18 with a testosterone measurement during our specified time period and who were not on anabolic steroids. The first part of our study, the goal was to really characterize the prevalence of testosterone deficiency, which we defined as having 2 or more low bioavailable testosterone values. And again, the reason we chose bioavailable testosterone values were because we recognize that a lot of our patients have conditions which would impact SHBG and thereby falsely alter the total testosterone value. The second goal was to establish patterns between total testosterone and bioavailable testosterone. So on the right-hand side, you can see the 4 possible patterns that there could be. Pattern 1, for example, would be normal total testosterone and normal bioavailable, whereas pattern 2 would be normal total testosterone and low bioavailable, and so on and so forth. Total testosterone was considered low if it was less than 8.6 millimoles, and bioavailable testosterone was considered low if less than 2 millimoles per liter. These values were extracted and paired to one another if they were taken within 3 months of one another, and these cutoffs were determined by our lab itself. Second part of our study was to use those 4 patterns that we established in part 1 and look at the following clinical parameters to see if there was a correlation. bone mineral density, BMI, lung function, antibiotic use, pancreatic status, steroid use, genotype, liver disease. And then part 3 is when we did a detailed chart review of the patients who were established to have low bioavailable testosterone in part 1. So let's talk about the results. So part 1, again, we had 345 patients, 288 had at least 2 measurements that were included in this part. And we can see that testosterone deficiency was seen in 10.7% of our population. That would be pattern 2 or pattern 4. And that would make up 31 patients entirely. So again, lower than what was seen in the literature prior to this study. 76% had normal total, normal bioavailable, and about 10% had low total and normal bioavailable, interestingly. The median time to a second repeat low total was about 2 years, and the median time to a repeat low bioavailable was 1.4. Now, what about part 2 when we look at clinical parameters? Now, this is a busy slide. I'll just orient you here. On the right-hand side, we have the data for our 31 patients who were established to have low bioavailable testosterone in part 1. And on the left-hand side are our patients who have normal bioavailable testosterone. You'll see that our rows in white, that there was no statistically significant difference amongst the groups when comparing pancreatic status, genotype, liver disease, lung function, BMI, transplant rate, death, or bisphosphonate use. However, when looking at bone mineral density, our patients with low bioavailable testosterone had lower bone mineral density at the femoral neck region, in addition to a lower Z score at the femoral neck region. However, when looking at the lumbar spine, there was no difference. Furthermore, patients with low bioavailable testosterone were significantly older than our patients with normal bioavailable testosterone. So the median age here is 50, whereas for the normal bioavailable, it was 33. Again, this is important as we make our discussion and our recommendations towards the end of our presentation. Amongst our patients with low bioavailable testosterone, those who were older and those who indicated more steroid use or hospital IV antibiotic use were more likely to have low bioavailable testosterone values, whereas those who had higher lung function, reflected by FEV1, or higher bone mineral density, especially femoral neck, were less likely to have low bioavailable testosterone values. Again, to me, this indicates that patients that are sicker, that have more steroid use, that have more IV antibiotic use, are more likely to have lower bioavailable testosterone values. Now, interestingly, I'll orient you to this graph here. On the x-axis, we have age, and on the y-axis, we have bioavailable testosterone. And each individual dotted line, which I'm sure you can't make out, is the variability amongst each individual patient and their bioavailable testosterone values. And the solid line that you see transversing through is the overall trend amongst our population. And what I take from this graph is that as our patients age, their bioavailable testosterone value gradually decreases. So we began to wonder, is there an age cutoff that we can determine from our data at which there would be a high specificity of having a low bioavailable value? And through our statistical model, we've determined that the age cutoff of 42 would give us a specificity of having low bioavailable testosterone of about 75%. Similarly, having a Z score at the femoral neck of less than 1.82 would have a specificity of 91% when trying to predict low bioavailable testosterone values. Again, this will be useful as we talk about our recommendations at the end. Now, moving forward to part 3. So this is when we did our chart review of the 31 patients that we identified in part 1 as having low bioavailable testosterone. 18 of these patients were seen by an endocrinologist. However, only 10 of them were seen specifically for the evaluation of low testosterone. The remainder were seen for osteoporosis, CFRD, thyroid disease, etc. Amongst those 10 that were seen specifically for the evaluation of low testosterone, 60% endorsed clinical symptoms. 90% had FSH and LH values done, of which 89% the values were either low or were normal. Again, that would suggest a hypogonadotropic hypogonadism picture. 40% had a brain MRI, of which it was grossly unremarkable. And interestingly, none of them were treated with exogenous testosterone. Now, as we come towards the end of our presentation, what are my take-home points for you? Well, number 1, the testosterone deficiency in our study, which is fairly large in comparison to previous, reports that it's actually much less common in our population. We saw a prevalence of 10.7%, whereas previous studies saw upwards of 35 to 45%. And I mean, I guess this could be because of improved nutritional status with our higher fat diet, as our CF patients are living longer as well. low bioavailable testosterone values are correlated with low femoral neck bone mineral density and Z-score, higher median age, lower lung function, increased rate of systemic steroid use, hospitalization, and death. Testosterone deficiency and cystic fibrosis may be a form of functional hypogonadotropic hypogonadism, which is the male equivalent of an athlete's triad that we often see in women. And that's corroborated by the fact that the LH and FSH was low, and the fact that it's correlated with systemic steroid use, hospitalization, and death. And lastly, 60% of patients who were actually seen by an endocrinologist actually endorsed clinical symptoms, which is a fairly large amount. Now, what are our recommendations from our preliminary data? We recommend targeted screening with bioavailable testosterone in the morning amongst those who have clinical symptoms, whose age is greater than 42, or if they have a femoral neck score of less than 1.82. Do not check testosterone when someone is unwell. Wait until they've recovered. If your first value is low, repeat the level. If testosterone deficiency is confirmed, consider checking the LH and FSH to understand the etiology and consider a referral to an endocrinologist for management. Now, future work would really include looking into if testosterone deficiency and replacement with exogenous testosterone improves clinical outcomes. And with that, I conclude our presentation. I'd like to thank you for joining me today. And if you have any questions or comments, I'd be happy to take them. Thank you.
Thank you for concluding our talks with that one. I really find that very interesting. I'm following patients through their lifespan, and testosterone replacement, I think, is going to be more on our radar as patients live longer and have healthier lifestyles. Our first question from our audience is, you excluded patients on anabolic steroids. How many were excluded?
There were 3 patients that we excluded that were on anabolic steroids, not a great proportion.
And were any patients already on therapeutic treatment and therefore excluded and not included in the percent who have testosterone deficiency in the males at your CF center?
That's a great question. We did not come across anyone who was already on exogenous testosterone in treatment. To double check this, we actually, for the majority of the patients, I actually did a periodic chart review as well to make sure we weren't missing that, and we did not come across anyone.
And when you are screening these patients with your testosterones, what do you recommend then as evaluation for follow-up once you identify these patients?
Sure. I definitely do want to expand on that further with regards to the recommendations of screening. So the first part is that from our data, we're recommending screening amongst patients, one, who are older than the age of 42, and that's corroborated by our data where we're seeing that patients who are of older age, their bioavailable testosterone is lower. Those who have a femoral neck bone density of less than negative 1.82, or those who have clinical symptoms. Now, I do want to expand a little bit further on the clinical symptoms piece. Amongst the 60% of patients who endorse clinical symptoms, the most commonly reported symptom was decreased libido. Now, of course, that's a sensitive topic to discuss, and I imagine that a lot of patients will not be as forthcoming with that. So perhaps the onus should fall on even the clinician, whether you're seeing them on a biannual or an annual basis, to screen for that as well. And that's something we're looking into our future work to see how we can actually adequately screen from a clinical symptoms perspective, with a caveat that, of course, decreased libido is a non-specific symptom that can be impacted by a multitude of reasons. Once you have your low bioavailable testosterone, definitely repeat that with a low fasting value if possible. And once confirmed, truthfully, I think an endocrinology referral should be facilitated. Again, amongst our 31 patients who had the low bioavailable testosterone, only 10 were seen by an endocrinologist, so about 1/3. So again, perhaps future work can be dedicated towards seeing how we can actually seamlessly facilitate that referral process as well, or how we can pick and choose which patients should be referred, perhaps based on the LH and FSH testing.
Another question is, do you find that one form of testosterone replacement is better than another for patients with cystic fibrosis? I find a lot are on gel, but I feel that they would do better on injectables. Could absorption be a further issue in CF patients compared to the general population?
That's an excellent question. And I mean, unfortunately, in our data, we did not come across anyone who was on treatment. So I would unfortunately be unable to answer that piece. But in our next work, one of our goals is actually to expand our patient population that we're looking at and even look into patients beyond the years of 2018. And if we come across that, that is something we would hopefully look into. And I'm happy to get back to you about that as well, if we come across that.
And in your center, who is responsible for the screening? Is it the pulmonary CF team?
So up until thus far, there hasn't been any dedicated screening. It has been the respirologists. They've been doing this annual blood work, although it seems as though even if the values are low or whatnot, sometimes they're really acted upon, other times they're not. So that's the part that we're trying to streamline with this data itself to see how often screening should be done and who should really be responsible for following up on it. But yes, thus far it has been the respirology team.
Yeah, I can see where that might be a problem if the pulmonologists aren't comfortable prescribing testosterone, because then it's information that's not able to be acted on.
Yep, exactly. So that's where we're trying to see if there's a way that if these patients are detected based on clinical symptoms and of course the biochemical abnormalities as well, if we can facilitate an early endocrinology referral as well.
In my center, we do some multidisciplinary work with the endocrinologists, and that's part of something that we're working on through our Envision grant. I wonder if, just having an auto referral for a certain age group of people, because bone health is important in any case, and that, is part of that. Be interesting to talk about other centers also and kind of how they're working on that, because I think it's probably something that has been raised at multiple CF centers. The next question is screening standard for testosterone deficiency at CF annual exams across all centers?
So again, that's an excellent question. Right now, there's no guidelines with regards to when to actually screen these patients based on the paucity of literature beforehand. So that's something we're actually working towards. Just historically at our center, this data has been gathered on an annual basis, sometimes even more frequently if they're doing biannual blood work, but there's no actual specific screening. So that's what we're hoping to actually propose based on our data.
And Dr. Brennan, do you have any other last questions before we close our session?
I have just asked everybody, are there any further questions to the whole team? So I've just put that into the Slido. I haven't got any questions back yet. In an ideal world, Neha, what do you think we should, at a countrywide level, do you think introducing questions on testosterone deficiency would be useful to go into the PortCF databases to really prompt it?
I think so. I mean, truthfully, it was as I was going through the chart review, I was stunned to see the lack of seeing these low values and then not seeing anything in the clinical notes with regards to there actually being follow-up. So I do see the value in actually asking, and primarily based on the fact that because it is a sensitive topic, I think a lot of patients will not bring it up unless specifically asked. And I think that's where the challenge is.
Yeah, I think that what this session has shown is a couple of things. One is, just looking at our expanded treatments and our expanded understanding of pathophysiologies of comorbidities of cystic fibrosis is really important. So I think that bench research that's been done is just fascinating. And then clinically, with the advent of triple therapy, we're really going to have to expand the way that we talk to our patients and consider their comorbidities, because we are really hyper-focused before, appropriately so, on pulmonary health. But now that pulmonary health may be more stable, this is really going to open up a wide array of other things that we need to be considering for our cystic fibrosis patients, and teaching our clinicians what is important to address will be, I think, a really important part of the next 10 years of cystic fibrosis care. So with that, I don't think we have any other questions. And I really want to thank all of our speakers and my co-chair. I thought this was an amazing session. I had so much fun. Thank you all for coming and talking. And I hope that you all enjoy the rest of the conference.